Hello everyone and welcome to another event of ant-neuro educational webinar series. My name is Farnoosh Safavi. I'm the head of education at ant-neuro and upstream product manager of speech mapping in Imagine. I'm very happy to be moderating today's session on assessments of hemispheric dominance for language in pediatric epilepsy surgery, from scalp electromagnetic fields to extra and intracranial stimulation. Our first presenter today is Prof. Stefano Seri, who is a child neurologist and clinical neurophysiologist with special interests in the development and clinical validation of functional imaging techniques to characterize intermediate phenotypes of developmental disorders. His main expertise is the preoperative evaluation of children with drug-resistant epilepsy, from scalp and intracranial EEG recordings to functional mapping of eloquent cortex with intracranial MEG, fMRI, and intracranial and transcranial magnetic stimulation. He has led Aston University clinical MEG activity for the last 15 years. Afterwards, Dr. Peter Bill will continue the presentation. Dr. Bill is a consultant clinical scientist and head of the neurophysiology department at Birmingham Women's and Children's Hospital. His main interests are pre-surgical evaluation of children with drug-resistant epilepsy and is the clinical lead for the Evoked Potential Service with a specific interest in visual electrodiagnostics. After this scientific presentation, ant-neuro application team will walk you through a recorded session of a speech mapping procedure with navigated TMS. There will be a short question and answer session afterwards, and you can send already your questions in the questions chat box so that we can discuss it after the session. Also, you will see some poll questions in the course of the presentation requiring your active participation as always. So Stefano and Peter, thanks again for accepting our invitation and being with us here today, despite the heavy workload you have in the hospital in this special COVID time. We are all ears and looking forward. Thanks a lot.
Thank you, Farnoosh, and welcome everybody here from Birmingham. It's not sunny here, so probably never is. I hope we can go through this presentation, and at the end you'll get some sense of how we use these methods that probably most of you are familiar with in a heavily clinical environment, and that's hopefully give you a sense of the journey that our patients go through. Just to make things clear, initially there's nothing in terms of conflicts of interest to disclose, and I'm going to start with trying to make you immediately understand how limited our abilities are and how little we know about language in clinical settings by reviewing what journey has the community, the scientific community, gone through from the time of Pierre Boca and the statement that we speak with the hemisphere, with the left hemisphere, based on a pure observation of case studies, to a situation where today imaging techniques have revealed not only a very almost a microscopic parcellation of the brain and the contribution that each of these areas that you can see in the middle part of the slide have to the production and the understanding of language, but also how these areas are interconnected. And here there are examples of models that are used and recent discoveries, for example, some white matter tracks that we, at least my generation, never knew about, like the fat or frontal Aslan tract. So we're actually, you know, in a clinical environment. So a neurosurgeon really cannot cope with this wealth of information. What they want is they want the patient to wake up without a deficit at the end. And I think complexity is often in the way of making those decisions. And these decisions become even more complicated when we think of pediatric age. Pediatric age is a time of enormous changes from the neural perspective. And I've just projected a slide of a recent paper that came out this year in the Proceedings of the National Academy of Science, where a longitudinal measurement of response to linguistic stimuli has been done. And as you can see, the brain does not necessarily speak with the left hemisphere only. And certainly in pediatric age, very early on, there's a significant bilateral representation of language. And that representation, at least in terms of the fMRI measures, which are one and only one of the many measurements we can make of brain function, change over time. So you remind yourselves of this picture later, because I have some images of MEG studies that I think are quite interesting to compare. So this fMRI study suggests that yes, there is a left lateralized language activation that starts kicking in quite early in right-handed individuals, at least in the large proportion of right-handed individuals. But in the early stages of development, there is a significant activity that is segregated to the right, the contralateral hemisphere. And the whole pattern of activation changes, but certainly the one that's most significant is the one on the right that becomes less and less evident. When we decide that surgery is necessary for a child who has failed to respond to antiepileptic medications, and we're faced with a decision of resecting one or small or large part of the brain, and that part of the brain has it becomes resected because it's responsible for the seizures, but also is also functionally active. And there's extensive literature. I'm not going to go through it, but the changes like verbal memory, visual memory are present after particularly left temporal surgery for verbal and right temporal surgery for visual. There are deficits in naming that have been reported, again, for temporal lobectomies. There's very little knowledge, at least not in large series, about what happens outside of the temporal lobe. Surgery outside of the temporal lobe is still a very little explored area. What we do know is a few basic concepts. One is that if the preoperative MRI, like in this picture, shows activation in the area that is contained within the resected zone, the area that has to be removed, then the chances of postoperative language deficits becomes very high, or certainly significantly higher. The other aspect that we learn with experience is that even if it is not, in patients who have bilateral pathology, for example, patients who have early on infectious disease that cause injury to both sides of the brain, even if they may have unilateral epilepsy, the area that is residual is requesting the collaboration of the other hemisphere. And so a resection of the non-dominant hemisphere can result in a reduction of performance anyway. So what are the key factors in predicting decline? This is something that we are asked by the families to say, well, okay, you tell me that everything will be fine, but if you look at it more granularly, what it is that we can expect. And certainly the factors that influence the decline are the technique that is used. Obviously, there are several techniques to remove the temporal structures within the temporal lobe, certainly the amygdala, the hippocampus, or the lateral cortex. The size of the area. There are studies that have shown that actually the larger the area, the more likely it is, as you would expect, for having deficits, particularly in naming tasks. The relationship between the resected region and the fMRI activation is something that I've shown you the slide before, and age of surgery and age at first seizure. So the earlier the onset of the seizure, in theory, you would have a brain that is not heavily lateralized in terms of dominance for language, but on the other hand, usually early onset of seizures are associated with disorders that have a poor outcome. And so the combination of the two plays a difficult role to disentangle very early on. It is also important to remember that whilst we look at hemispheric dominance, recent studies, and I'm just quoting some of them here, have shown that it is not enough. We have to calculate our laterality index on the basis of areas that are putative areas that play a role in language function. So you don't work on a whole brain level, but you work on regions of interest level, particularly inferior frontal gyrus and Wernicke area. And the first being an anatomical structure, the second being more of a functional definition, construct. Also, we are asked to predict the impact in terms of post-operative ability of the patient to be reinserted in school and start their daily activity. What we know, as I intimated initially, is that a large percentage, up to 94% of the healthy individuals have a left hemisphere dominance for language if they're right-handed, and that these are the structures that we look at mainly when we look at clinically. You know, we are aware of the picture that I showed you at the beginning, but clinically we focus on inferior frontal gyrus, middle frontal gyrus, particularly the Broca area, supplementary motor area, and superior temporal in the temporal cortex, as you see below, superior and angular gyrus. Is a strong lateralization predictive of decline? And that really depends on how you see models. I'm not going to get into great detail here, and I've left a slide for later if someone wants to go through them. But certainly there are models that predict that the higher the degree of lateralization, the better the performance is, and a brain that is not heavily lateralized does not perform as well. But today the view, as intimated on point 3 of this slide, is that there are genetic factors that determine how lateralized an individual's brain will be when it comes to language function, but also it's quite evident that the postnatal events and plasticity, brain plasticity plays a significant role in that. So what do we use? Well, we use different methods that have different properties. Hemodynamic response, one, the one that has gained the most widely kind of accepted clinical role, particularly fMRI. There are studies that have looked at near-infrared spectroscopy, but fMRI is definitely the one that has gained much usage in clinical practice. We, being electrophysiologists by initial training, are clearly interested also in looking at other methods that look not at the byproduct of the neural activity, but the neural activity itself. So looking at EEG and MEG. And these techniques obviously have a very high resolution in terms of time. When we operate clinically, we have the opportunity to look in closer to the brain and within the brain through two techniques. One would be the stereo EEG, which is placing depth electrodes in specific areas of the brain, or strips and grids, which are placed subdurally on a convexity. And when we do that, we have the opportunity to stimulate directly the brain and induce responses or prevent responses from happening. Pete will talk to you about creating functional lesions, and these are exemplified by navigated repetitive transcranial magnetic stimulation. The gold standard is the WADA test. You've all heard about it, so I'm not going to spend a significant amount of time other than in recognizing the work that Yun WADA did. He's a neurosurgeon who described that anesthetizing one hemisphere can suspend the activity of that hemisphere if it is dominant for the function that we're trying to explore. This is a gentleman's picture, and it's now difficult to use clinically, clearly, because in pediatric age, you'd have to wake up the child in a very unfriendly environment, usually what we call a cath lab, a laboratory where the catheters are inserted in the femoral artery and driven up to the cerebral artery. So it's not something that's very pleasant. It has morbidity, and as I said, it's not friendly. The problem with techniques that have replaced WADA test is that they're often failing at the very task that they've been requested to perform, which is ability to localize in presence of lesions. This is a paper by Christian Elger's group that have shown quite, I think, undeniably that the closer the lesion is to the area that you're investigating, the more likely it is that your activation pattern will be disrupted, purely because you're measuring vascular changes, you're measuring the byproduct neural activity and not neural activity itself. I'm going to pause for a second and allow, I think, the directors to run a poll, which I think will be interesting.
Yes, the poll is ongoing, and let's give it 30 seconds or so. Okay, so here are the results. 63% voted for low spatial resolution, very high temporal resolution, and minimally invasive. Do you agree with that, Stefano?
Yeah, I think it's nice to be on the same page. Obviously, I think when we look at the temporal resolution of fMRI, it's somewhere in between PET, which is very low, because it integrates the activity over several minutes, because that's the amount of time it takes for the radioactive material to concentrate in the area, and EG, which is obviously different. So the spatial resolution is very high as well. So we're doing well here. And with techniques such as electrophysiology, we're in search of biomarkers. So we're searching for measurements that will allow us to differentiate regions that are active from regions that are not, or individuals that are left versus right lateralized. Some of the markers that have been proposed are in the frequency domain, which means that we can use the analysis and the results on the basis of changes in power in specific frequencies, and looking at event-related, what used to be called desynchronization, or increase in or decrease of power in the theta alpha band. Beta band desynchronization is very useful, particularly for movement, and gamma band augmentation, so increase in power in the frequency, in the high frequencies between 40 and 100 hertz, is very, very much used in clinical practice for language. But if we average the data in the time domain, then we can look at topography of the evoked potentials that are resulted from the averaging procedure. We did a study some years ago on healthy individuals looking at MEG. MEG and EG are pretty much capitalizing on the same properties and features with their own strengths and weaknesses. So what I'm saying here applies to both EG and MEG. The advantage is that we don't work in an environment that's hostile, and kids can respond to the questions in a natural way. Some of the tasks we use are verb generation. We have a presentation of a word, for example, like flower, and the patient needs to think of as many verbs that are associated with that word. For example, flower, you could think of picking flowers or donating flowers, or something like that. And what you do is you actually are able, after some manipulation of the data, to look at data in the source space, or where are the changes occurring. And in blue here on the top left, you see reduction in power, so negative values, and blue in the area in the alpha band, roughly around between alpha and low beta. This is in Brodmann area 45. You see significant reduction in power higher up in beta, and this is all in the left hemisphere, in the language dominant hemisphere, but you also see a pattern which is very interesting, and it's increase in power in the contralateral hemisphere. And that's something that we see constantly all the time. And there's hypotheses as to what this modulation of alpha power increase is, and usually it's considered to be, there's Ole Jensen from Birmingham has published quite a lot of data suggesting that this is effectively a way for the brain to suppress the activity of the right to enable the left to perform its task. And their data is pretty concordant. So if you look at the same patient undergoing fMRI in the same paradigm and here and MEG on the left, you can see that the results are pretty much the same at the level of laterality. And this is just showing you a difficult one, a right hemisphere dominant patient, in which you can see the asymmetry in the bottom right corner for the MEG. MEG has much more spatial blurring. It's not as I would say, pinpointing in terms of the regions, but the results are pretty compelling. And when we apply this clinically, it's a recent paper that we've done, we compare with what we can get to when we stimulate electrically different regions of the brain, and we can actually compare areas that are involved. So the DCS, direct cortical stimulation validation, works very well for this laterality of the inferior frontal gyrus and the posterior regions for the temporal gyrus. We can also look at connectivity, but this has yet not had a significant impact on clinical decision making. There are different patterns for different bands, and this is something very interesting. I put it up for those of you who are interested in looking at it. Finally, I'm going to talk very briefly about intracranial recordings. There are two ways of doing this. Stereo EEG, which is a window on cortical function that is opened by inserting electrodes inside the brain in regions that are relevant for the seizure pattern and/or regions that are relevant for function. Clearly, these are almost point-like electrodes that have a very small area of capturing activity, and certainly makes eloquent cortex mapping more challenging, but not impossible. The electrodes are implanted using a robot in the brain, and the planning is done using all the information we collect non-invasively. So EEG, MEG, PET, whatever we have available can be co-registered. And as you can see, this is a paper that the group in Marseille published not long ago. When you use Stereo EEG, you can actually get beautiful N1, P2, and 400 paradigm data in language and speech perception. So they were looking, obviously, semantic congruity in the N400 paradigm. We use a lot of it for looking at receptive language. So this is a study where we use spectrally rotated words. So we can use a word that's a standard word, like balloon, and we use a word, a sound that is the spectral rotation of the same word.
Balloon.
So you can tell that it's not intelligible with respect to balloon, but it has the same spectral profile. So the high frequencies are rotated to the low. And in all the regions that are activated, we can get beautiful evoked responses that we don't get anywhere else in the brain. And so we have evidence from this recording, for example, of a significant contribution of the basal temporal to the language production. We know that. We have evidence of the superior temporal gyrus, and we have evidence from right here, and we have evidence from the inferior frontal gyrus. So it's quite nice. For rotated speech, it's clearly more the posterior language regions that we're interested in, and so there you go with the ERPs in the posterior part of the superior temporal gyrus, edging towards the angular gyrus, And the superior temporal gyrus in the middle, the electrode T, and I, the more anterior part of the temporal lobe. Just briefly, and then we can probably move on very quickly. We use gamma band augmentation, so increasing power in this gamma band, which has been shown by a lot of people as being extremely useful to localize language active regions. And this is more or less what you see. So you see a suppression in the alpha band, alpha beta band, but an increase in power. The red is actually activation or increasing power in the gamma band when looking at tasks that have a linguistic connotation. So this is verb generation, for example. And the same in the electrodes, lateral electrodes T9, T10, which are here on the superior temporal gyrus. There's data on pediatric age. Doug Rose in Cincinnati and the group in Cincinnati have published some of this data not long ago. It's quite interesting, and we use it quite a lot. This is the original data by Nathan Crone, who described this method many years ago. And we can also average those responses. And again, this is a verb generation paradigm, and we can see that we get activation in the electrode J lateral, which is the Broca area with the beautiful ERP. And we get activation in the operculum, we get activation in SMA, and we get activation posteriorly in the temporal regions. Okay, so I think we can have a break for a question, I suspect, at this point. I cannot hear you, but
yes, so the poll is ongoing, and we will let you know as soon as we close it. We will share the result.
Whilst my friends and colleagues are looking at it, I'll leave some space for Pete to sit down.
Okay, the results are very interesting because they're almost equal, and it shows a level of uncertainty about the answer. So 31% of the participants voted for the first option, age at first seizure, gender, and high lateralization index. 31% again voted for high lateralization surgery in dominant hemisphere, bilateral pathology, and 38% extent of resection area, gender, family history for epilepsy. Which one would you go for, Stefano or Peter?
Well, I was a little bit deceiving, like you can be when you don't have to answer a question. Obviously, some of the answers, all the answers contain some truth, but the answer 2 actually is the one that contains the whole truth. Let's put it that way. So B is the answer to this. Bearing in mind that some of the items in question A and C are correct as well.
Sounds interesting. Thanks a lot to Stefano, and let's get to Peter's presentation.
Yeah, good.
Right, thank you, and good afternoon. So I'm just going to pick up from where Professor Seri has left me onto looking at functional lesions. As we talked earlier on, that we're engaged in an epilepsy surgery, a pediatric epilepsy surgery clinic. So these are patients, these are children. There's great variability in the way that they may comply with the investigations. So we've put together a technique, a testing strategy for understanding A, whether we can lateralize language, and B, whether we can localize it. And we do this using our navigated repetitive TMS system. So just to briefly touch on what Professor Seri had already talked about, which is direct cortical stimulation. So we do some of this, in particular for motor mapping. The surgeon will have the prong, as you can see in point A. He will place it onto the cortex, stimulate electrically, and we can record motor movements in the arm. When it comes to speech, that's much more complex in pediatrics, because what you don't or aren't able to do is wake the patient up on the table to do a proper assessment. So in the absence of the ability to do a wake-up test, the direct cortical stimulation as it stands is not particularly useful for mapping speech. So what we can do, and again this was shown earlier on, is implant grids, and we can do stimulation and various testing at this moment in time. But again, there's always the issue with compliance with pediatrics, and that there are other inherent risks with this particular technique. So what we're trying to do is understand whether we can give the surgeon information in advance of the surgery, and preferably that being non-invasively assessed. So I'm sure many of you already know this, but this is the system that we have here. And TMS, it's a non-invasive, pain-free stimulation of the human cortex. I put the words pain-free in there. It's typically pain-free, the areas that we're stimulating. However, you may sometimes impede on the facial nerve or the trigeminal nerve and cause some discomfort. So this is all about technique. It is an established method in clinical neurophysiology. We assess in the same way we assess SSEPs. We can assess entirely the integrity of the corticospinal and cortical bulbar motor pathways. We can assess spinal cord and roots, and it does so using by generating a magnetic field using a copper coil. The TMS induces intracranial current, which effectively causes the transient membrane potential changes and triggers the action potential, which is what we end up recording for the motor part. So we have different types of stimulation. There is single pulse, that can be monophasic or biphasic, and this is typically the trigger that you use to record evidence of primary motor cortex. We can add a bit of facilitation, so do a paired pulse stimulation, so two temporally related stimuli to facilitate brain excitability. This data is much less published, but it is still available as a technique. And then what we'll be talking about now is about repetitive TMS. So this alters the neuronal excitability for a period of time that may outlast the stimulation duration as well. And this is what we refer to as the functional lesions. And just to let you know, there are different types of coils. We here use a figure of 8 coil to get a better sensitivity of the stimulation, and there's a variety of different methods in which you can use those. So how do we use or choose the stimulus site? Well, you've seen all the data recorded through MEG, fMRI, and this is very similar information. This was a paper reported though looking at the anatomical regions and the correlation between direct cortical stimulation in particular and TMS. And what we see, if we link these, is that there's significant correlation between the direct cortical stimulation and navigated TMS sites. And in particular, looking at areas like the pars opercularis, the supramarginal gyrus, and the supratemporal gyrus. So these are the sites, the anatomical sites that we target with our repetitive TMS. So this is the service. So effectively, we use a series of optical positioning tools and sensors to be able to 3D localize the patient. The tracker allows on the coil itself, allows us to understand where the coil is positioned in relation to the patient's brain. And this is what navigated TMS adds. So we utilize the patient's MRI. So in the cases that we're talking about linking to pediatric epilepsy surgery, the cortex itself may be abnormal, may have already undergone pre-existing surgeries, and therefore it's very important for us to ensure that we have the patient's anatomical data uploaded, and therefore we can use exact positioning to understand where we are to influence the surgery. So this is our technique. We use the Visor 2 navigated TMS system. We have this figure of 8 coil. It's placed on the child's head. We apply EMG recording electrodes along the arm, including hand and upper arm, and we stimulate perpendicular to primary motor to reproduce a motor evoked potential. Once we've done that, we'll track around the area. We've identified a site that's most likely to be able to stimulate hand motor, for example, but then we'll track around, and the idea is to find the lowest possible stimulation intensity, so the resting motor threshold, and we record that response to stimulation of each hemisphere. Then we do a picture naming trial. So the patient will undergo a series of pictures. They'll do this naming trial twice, and any pictures that they don't understand or misname, we can remove. The interpicture interval is of 5 seconds, and the display time is 0.7 seconds. And we do this, as I say, twice to ensure that the pictures the patient is familiar with and is able to respond quickly. And then we do it with a series of stimulations, and we target the pars apicularis and the inferior frontal gyrus, and we do that on presentation of the stimulation of the picture. So in order to successfully introduce a virtual lesion, there are essentially 3 criteria to be met. We need the coil positioned correctly, so it needs to be over the appropriate anatomical areas. We need to deliver the stimulus at the correct time, so it must be at the point at which the image is being presented. We need to be able to deliver the stimulus, and that stimulus needs to be of sufficient intensity to disrupt the function. So the frequency and intensity of the stimulation must be sufficient. Then during that, we look for errors. So there may be no response, there may be a performance error, there may be phonological paraphrasias or semantic paraphrasias or verbal paraphrasias, and then neologism. So effectively, the patient is videoed all the way through this, and it may be that we have to go back and look to see, in particular, about performance errors. There's one thing, them stuttering or struggling to reproduce a sound, but then you have to look at that in accordance with any stimulation of the facial nerve. So our stimulation parameter, we use 100% of the resting motor threshold. We use 5 to 7 hertz stimulation for 2 seconds, and it's a 90-degree angle from the cortex in anterior-posterior orientation. And this comes from a paper from Solman in 2018, and they looked at the performance for the anterior and posterior stimulation, and actually what they found is the biggest number of responses or positive interruptions of speech were using 100% of the resting motor threshold. And for anterior stimulation, 5 hertz was preferred, and for posterior stimulation, 10 hertz was preferred. And this was just in relation then to the orientation of the the stimulation itself. So a 90-degree angle was preferential for anterior stimulation. So there are certain considerations for pediatrics. As I say, pain and discomfort, it can happen, in particular if you're stimulating close to face motor or come further down in towards the facial nerve itself. So it's just something to be mindful of, because we have limited compliance, and a compliance aspect is a big part of this. These are children. They have a duration at which they're prepared to tolerate investigations, and that typically is a finite amount of time before they give up. And therefore, any testing that we do needs to be rapid. It needs to be, we need to be confident in the data that we're collecting. It's important about the accuracy of the resting motor threshold. We need to ensure that the stimulation intensity is appropriate. What you want to reduce as much as possible is the cross-activation of the face motor cortex, as we saw in the video just. Coil temperature can be a problem. There are cooled coils, but we don't have one of those. So we have to ensure that the duration of stimulation or the duration of the testing time is sufficient to allow us to cool the coil in between stimulations. And analysis. You always have to be cautious about hesitations to ensure that it's not due to the stimulation itself, just putting the patient off or making them not want to talk, rather than actually interrupting the language function itself. So as a summary, navigated TMS or navigated repetitive TMS is a relatively new mapping technique for cortical functional localization, but it is proving to be helpful and informative for our preoperative diagnostic investigations. Several recent studies have shown that the accuracy of the technique is comparable to the gold standard, which is direct cortical stimulation. And we've proved that pediatric patients are able to tolerate and comply with the procedure. There are many acknowledgements on this slide, but I would like to draw particular attention to Mrs. Winifred Hutchinson, who is a advocate for Birmingham Children's Hospital. She's a charitable donor who was the sole donor who allowed us to purchase the navigated TMS system, and it's due to her generous contribution has allowed us to move in this direction and support our paediatric epilepsy surgery program. So huge thanks to her.